Developmental milestone. Now, at 6 years old,
Yes.
can she write her own name? Can she at least read simple sentences?
She understands sentences and she's able to write some of the letters.
Okay.
Doesn't really follow like
So
complex
if
words.
you putting your gross motor able to walk, run, skip, fine motor able to copy triangles, speech able to speak in full sentences, social dress without help but has no friends, cognitive able to recognize letter. For 6-year-old doesn't sound like this a 6-year-old. You must basically do but ask about what 6-year-old can do. Okay. The question like can she basically write letters already or not? Not just recognize. Because at 6 years old they are already 1 year going to primary school, so you probably have to ask school readiness.
Right.
Understand? This one is not asking for school readiness. This one, so you basically have to go through at what age they are currently now. At 6 years old, go through the 6 years old, make sure they are able to achieve that one, then you don't have to worry about the rest. If at 6 years old unable to achieve yet, then you have to go down. At 5 years old, 4 years old, 3 years old. After that, you summarize from that history what is the developmental age. Okay. Developmental age is probably you can either summarize it gross motor, fine motor at 4 to 5 years old, and then speech and social at probably 3 years old. Okay, and then you can tell patient has some global developmental delay less than 5 years old we call global developmental delay. More than 5 we call it intellectual disabilities. Okay, I think probably I just want to add a bit more on the school readiness, yang the one we discussed about the milestone, developmental milestone. School readiness, what do you need to ask about school readiness is basically whether they first in terms of social skill they are toilet trained or not. If they're not toilet trained, they're not school ready. If still wearing diapers, they're not school ready. Okay, and then if they are in terms of fine motor, they can hold their pencil, their tripod grip is good or not, because there are be a lot of fine motor skill involving your writings, using scissors, whatever lah. Okay, that's another thing. Another thing about school readiness, language skills lah. Language skill is the conversation, whether they can speak in full sentences, they can understand conversation, they can basically make people understand them. Okay, that's important because school is a two-way learning lah, back and forth conversation. That's one thing. Another thing, whether they have behavioral issue or not lah. So they have behavioral issue means like they are ADHD, autism, they cannot social wise, they're not there yet, then they're not school ready. Okay, if disturb other people, that's a problem lah. But if the teacher call you, you don't respond, there's no two-way conversation. So that's why autism, ADHD is very important thing you need to screen lah at 6 years old, 1 year, 2 years before they go to primary school. Okay, all these things probably can be picked up lah during the preschool time lah. The teachers are very good at this lah, because they basically can see how the child respond and all that. Okay, I think lastly in terms of gross motor is the any physical limitation or not lah. If patient got underlying neurological problem, but cognitive wise they are okay. But somehow lah, the class 2, 3, 4 stories classes and probably need some letters from medical doctors to say patient have any problem, if they need special treatment, probably need to put the class, which is I think all can be arranged lah. Okay, lastly in terms of cognitive skills lah, the thinking skill, where they can do some simple calculation, can understand, can do some problem solving lah. They need to have that skill also lah. If simple skill like macam 1 + 1 also cannot solve, so probably they're not school ready lah. Probably have to go into the special stream, which is your PPKI and all that. But that one need OKU card because of learning disabilities. Okay lah. So at 4, 5, 6 years old for developmental milestone screening, you must screen for that. You examine child with neuro problem.
Clinic routine sleep.
So, on general inspection.
Muscle wasting.
Lagi? Sama? No, just general examination on the face and all that.
Any dysmorphism.
Dysmorphism, right? Okay. So, if patient got dysmorphism, then the likelihood for the seizures to be syndromic is more, right? Okay, or metabolic. Okay.
There was no dysmorphism. However, I felt that she had ptosis, maybe because she was lethargic
What, bilateral ptosis?
Yeah,
Oh,
she was.
bilateral ptosis can mean sleepy je lah.
Yes.
kalau unilateral then possibly congenital. Okay, sometimes if you doing works so long, you basically just staring at computer doing your whatever lah, thesis whatever, then sometimes you probably have some acquired ptosis temporarily. Okay, it can happen lah. Alright. Okay, so that one thing other than dysmorphism, what else we want to look for? And the general inspection for neuro patient.
Any stigmata of
What stigmata?
neurocutaneous sign.
So neurocutaneous stigmata. Example?
Cafe au lait spots.
Cafe au lait one. Some more?
Neurofibroma.
Can. Some more?
Ash.
Ashleaf or hypopigmented lesion lah, which is your ashleaf. Hyperpigmented, which is can be your cafe au lait. But don't forget some other thing like your port wine stain. It can be your stalk bite also lah, but stalk bite is just basically small hemangioma lah, but can be related, just cannot be related lah. But most of the time neurocutaneous stigmata, all those hypopigmentation and hyperpigmentation, specific lines lah like blush core line. Have pernah dengar? Never heard of blush core line? Never heard lah. Okay, all those examples lah. Okay, alright. And then okay, so specific for upper limb and lower limb examination. The next thing basically you examine your, don't write your inspection, you examine your, look for what?
Muscle wasting, gesticulation, maybe contracture, abnormal postures.
Okay. Plus, under general inspection specific. If we got neuro station, one of the thing we must do, other station don't have. Inspection lah.
Apa lagi? Just general.
General. Can be specific also. Gate.
Yes.
Don't forget about gate. Okay. So neuro specific, they have gate extra lah. Alright. Because from the gate can give you a lot of clues. Okay. Sometimes you have hemiplegic gait, so you know lah this one, your examination towards the upper motor neuron sign. Then you have diplegic gait, upper motor neuron sign, specific for prime VCPs. Okay, hemiplegic gait, probably some thromboembolic event lah, due to multiple reasons. Okay, alright. So for postgrad level, yeah, we always insist on them to examine gait from the beginning, so that you can like basically stratify lah which one this way it will go. Alright, it can be specific problem either lower motor neuron or upper motor neuron. Okay, then your contractures also give a clues. This one kalau very prolonged, long standing problems, then they will have some contractures lah. Okay, then hypotonia also pointing towards is it upper motor or lower motor neuron lah. Okay, some those yang neuromuscular junctions problem, they are hypotonic lah. Okay, then you also need to know lah, hypotonia also can be divided into central or peripheral lah, or we basically much easier way to classify is floppy strong, floppy weak. Okay, example floppy strong. Can, but cerebroplasty in the long term they become hypertonic lah. Alright, ada example of floppy strong?
Hypoxic.
Duchenne floppy strong, is it?
Hypoxic ischemic.
Yeah, initial lah, the initial part. Okay, I mean basically it's a brain issue lah, rather than neuromuscular issue or syndromic. What syndrome? Floppy strong? Down syndrome, some more? Prader-Willi. Itu satu examples lah. Can be Pompe also, but Pompe very hypotonic lah sometimes. Okay, but the floppy weak example?
SMA.
Yeah, SMAs. I think Duchenne also can be, but Duchenne present late lah, so they don't present with hypotonia lah. Okay, but those basically the SMA lah, the most common examples. Alright. Okay, next.
So for provisional and differential, by provisional.
So LFT important in seizure cases. Why?
Bilirubin for the NCAF.
Okay, sama.
Maybe coagulopathy and then like seizure mimic stroke, like bleed in the brain.
Can, but if you have patient with seizure, you want to start something, right? Especially those come with status. What medication do we start to basically control the seizures during the
or
2 minute lah?
diazepam.
Some more during the acute part. Phenobarb. Some more. Yeah, phenytoin. So what the side effect of phenytoin? Liver transaminase lah. Those are the most common side effect. So LFT is a must lah. As a baseline and also maybe monitoring later on lah. Okay, but the good thing about phenytoin, we don't really start them as your maintenance lah, but only during the acute phase you want to control the seizures lah. Once the seizure control, you already started some other anti-epileptics, you may taper down phenytoin. Okay.
So, doctor, if a child has signs of chronic liver disease, then we don't give them phenytoin. So,
You can still give, but you still need to monitor lah. But those yang chronic liver yang very very bad, we try to avoid it lah. Okay, you can start other medication lah, like Keppra or midazolam and all that. Okay. If you decide for MRI, what are the advantage of MRI over CT?
Low radiation.
Okay. What else?
Better soft tissue resolution, and like you can see the fluid and also how words with fluid.
Okay. But the problem with MRI? Time consuming. Okay, some more? Other than time consuming? Sorry? Narrow space? Claustrophobia. Okay. Practical in the practical practice, our daily practice, what are the problem to get MRI? It's not just about cost effective, it's very difficult to get. It's very limited slot available. You only have 2 machine. Okay. And then you probably have so many people want to request MRI on top of the MRI appointment that already been scheduled. Then suddenly you want to request something urgent. So to get that one is very difficult lah. So in terms of practicality, MRI is a bit less practical compared to CTs because very difficult to get. Unless the indication very very strong, then you can get it. If the indication not very strong, most of the time it will get rejected. Okay, by the radiologist. Okay, so in terms of the choice, CT scan is still the first line because it's much easier to get. It's shorter time to do. Probably we have more CT scan in our hospital compared to MRI lah. There's CT scan in emergencies, there's CT scan in radiology department. So it's much easier to get lah. And then one CT scan probably can take 5 to 10 minutes lah. Okay. So CT scan advantage is what?
Better resolution of anatomic.
What are the more sensitive?
bone with better viewing bone.
Okay, some more. They are better at viewing. Seizure related. What can cause seizures other than
Stroke.
bleeding lah? So it's much easier to pick up bleeding on CT scan lah compare MRI lah. Alright. Probably because of the resolution thing. I don't know lah. I'm not a radiologist. Okay, but for bleeding, it's easier to see bleeding in CT scan. Okay. Of course lah, the problem with radiation lah. So one CT scan equal to how many X-rays?
14.
I think about 100 got. I don't know. Some say 1,000 lah, but it's range around there lah. Whatever it is, radiation is a lot lah. Okay, because yeah, you get nice pictures, but radiation is a lot. Okay, for this case, yeah, all the basic baseline investigation must be done. Blood culture just basically to raw infection, sputum for pneumonia. IEM will only be considered if you are suspecting metabolic or syndromic cause of the seizures. If patient have developmental delay, have specific neurological signs, dysmorphic, then it's very strong indication to send for IEM. Okay. CT scan is basically baseline, considering the frequency of the seizures for the past few days, right?
Yes.
4 times. So you want to rule out acute thing first, which is your bleeding.
Right.
Okay. And then sometimes you can pick up the meningitis also lah. So meningitis on CT scan, what are the findings on CT scan with contrast? Not really. Yeah, leptomeningeal enhancements lah on CT scan with contrast lah. Kalau plain cannot see. Okay. Alright. So because increase in vascularity due to inflammatory process pick up a lot of contrast, so they will become more enhanced.
But in meningitis, it's the best method to determine meningitis is by lumbar puncture.
Of course lah. The meningitis is clinical diagnosis. You support it by doing LP to confirm it lah. Sometimes you pick up this letter meningitis enhancement also lah, because sometimes you want to do through a bleed, right? Especially those come with status epilepticus lah. Because this one 4 years without seizures, then suddenly got datang 3 to 4 times, so many episodes. Okay lah. So sometimes you're not sure you're dealing with, so sometimes we requested lah. Okay, not everyone lah. Okay, kalau there is no specific history of fall, there is no specific history of like trauma to the head, and then clinically examination normal, then probably you don't request it. But if patient comes status 20-30 minutes, no, don't stop, even though it's just one, sometimes we do request as well. Okay, because we just basically want to raw to bleed, but because the eye examination and all that is very difficult to do lah. Okay. Yes, kalau first episode of febrile seizures, you probably want to get EEG appointment outpatient lah. Okay, because one episode probably may develop second, third episode latest lah. Alright, but at least one episode of febrile fit is indicated already lah to request for EEG, but it's not urgent, so you can request for outpatient. But seizures frequent, very difficult to control, you need urgent EEG lah. Okay. But febrile seizures, if datang first time febrile seizures, you don't really start medication from during the admission lah. You probably start maybe second, third times after counselling. Usually by first time, parents still quite resistant to start, but already second, third time they're much easier, much open to start, because they already seen it happen repeatedly. Okay, alright. Okay. So next, development of CNS neurulation. So the problem during the neurotube formation is your spina bifida lah. Okay, spina bifida also include your anencephaly. Alright, encephalosis is just different location. So it can happen from the brain down to your spinal cord at the lumbar region. Alright, so it can happen at any level and difference of severities. Okay, spina bifida occulta is the less severe form lah. Okay, so anencephaly is the most severe form lah. So what medication ni expecting mother they need to take? Folic acid. Why? It can help with the neurotube formation lah. Okay, because it's proven if folic acid is deficient can affect the neural tube formation. Okay, so it's not when positive pregnancies you must take folic acid during that time. If you are planning to get pregnant, then you probably have to start taking it already. Okay, not just if you positive, you already positive about 4, 6 weeks, 7 weeks post pregnancies, post your last menstrual cycle, 5 weeks, 6 weeks later, then at the time you know you're pregnant. So that one already 4 weeks off, the embryogenesis has happened. So to reduce the risk, so they must take folic acid even they are pregnant. Okay, when the planning itself started, they have to start taking already. Okay. Alright, so the next problem at the regionalization. So problem here is holoprosencephaly. So you will see from time to time babies come with this problem. So basically the structure of the brain is not normal. Basically the brain, they are funny in shape, small, very abnormal shape of brain. Okay, so when they have abnormal shape of brain, they cannot develop normally. They can have so many problems. So on top of it, they can have problem with other organ as well. So, okay, this one most of the time can happen isolated problem. It can happen with syndromes. Okay, what are the fatal syndromes that you all know of?
For what, sorry?
Fatal.
Fetal alcohol syndrome.
That can be fatal, not fetal.
Anencephaly.
Okay, some more. The trisomy. Which one is fatal? 13 is what? Patau or Edward? Patau. Okay, tembak je. 18? Edward. You got 50-50 chances. Okay, you either die or live. Okay. So the advert that we had recently, that baby also has HoloPro Scientifically as well on top of the large VSTs. Okay. Alright. Okay, so neurogenesis, all these things can cause microcephaly. Yalah, is baby that are born microcephaly, we have to investigate lah. So I think the practical thing that you all need to take is you must plot the growth chart. Okay, if just by observation, it's very difficult. Okay, unless you already been practicing for quite some time, you can basically notice the head looks small for the age. Okay, then to confirm it, you must plot on the growth chart. Okay, then if confirmed small by the objective measurement, then you must send lah. So we usually send what viruses in babies? If microcephaly or SGAs, small for gestational age. Torches, don't forget about torches. Okay, so I'm giving you all the practical thing lah. We don't send Zika, we don't send all this funny thing lah. Okay, torches is still basically very common, very popular investigation we send lah. Okay, for all sort of reasons. Okay, SGAs, IUGR, microcephalys. Right. So T stand for what? Toxo. T and O toxo R. Rubella. C. CMV. H. Herpes. Okay, HES herpes lah. Okay, herpes 1 and 2. Right. Okay, migration. So migration, smooth brain. Okay lah, all these things I have nothing to add. From here, synapses problem, nothing to add here. Myelination, multiple sclerosis, you won't see lah in pediatric, most very rare, can happen but more common in adult lah. Alright. But yeah, the thing here, myelination is ongoing process lah during the brain development. The brain development happen at the most at what age to what age? The myelination. So the first 3 years is the most crucial one. Alright, the first 3 years is the most crucial for brain development lah. It can happen, still continue after that, but that's why sometimes we are afraid to stop medication, especially your thyroid medication. If diagnosed congenital hypothyroid, we basically continue the thyroid medication until 3 years of age. Then after that, we can try to stop it. Okay, because we don't want to disrupt the brain development during the first 3 years. Okay. So apoptosis sesame. Okay, continue. So use and abuse test for seizures. This one, yeah, EEG. What does it say here? Sensitivity of inter-etal EEG is too low. So if patient is well during that period, no seizures activity at all. If you do EEG, it will be normal. Okay, so the best thing, if the seizures still happen, recurrence, from the video looks like seizures, from the history looks like, sounds like seizures, but on EEG already done, all normal, but somehow the history still keep coming back with recurrent seizures, sometimes we do video EEG. Means we admit patient into the ward. That ward already has cameras, has EEG machine, so they connect the EEG videos, then we record lah, capture the EEG semiology, capture the seizures semiology, and capture the brain activity during that time. So you can, the neurologist basically can see the type of semiology and the brain activity during that time, then they can make diagnosis lah, which type of epilepsies. Okay, but not everyone will go for video EEG lah. I think the patient with underlying so-called epilepsy but no specific diagnosis, recurrent seizures quite difficult to control, but sometimes we do video EEGs. Okay, because sometimes when you get history, the history is always GTC, but most of the time they miss the initial part, which is the focal onset. So the focal onset of, they start with the one side first, then later on they become the secondary generalization. Okay, so the focal onset is important, right? Sometimes they, in the midst of chaos, in the midst of the hectic part during the panic, during that seizures happen, you very difficult for parent to tell lah. Okay, so that's a good thing about video EEG. Alright, okay, continue. The management of febrile fit. Okay, I think this one you all need to know very detail lah, because when you work later, you all expected to manage it. Even without medical officer, you all need to know how to manage it, how to advise, and how to counsel parent. Okay, then this is one of the favorite topic for assessment lah during the house officer time. Okay, so acute treatment of prolonged cluster seizures. Yeah, okay, all these things I think I'm not gonna go through all these things. You all need to know how to manage seizures. Okay lah, oxygen, diazepam, PCM, yeah, left lateral, right lateral doesn't matter lah, as well as lateral. Okay, if more than 5 minutes, then probably you want to start some anti-epileptic lah, like phenytoin or phenobarb. Okay, the prophylactic treatment for fever. So this one said antipyretic does not affect the incidence of febrile seizures. I don't advise them to give PCM if no fever, but I do advise parents to check the temperature if they are suspecting the child looks unwell or the child feel warm than usual. They must check the thermometer. So the advice we give, they must have thermometer at home. They must check the temperature if they suspect their child having fever or feel warm to touch. If temperature more than 37.5, 38, then you can start giving already. So instead of being prophylaxis, early PCM on time is much more feasible advice lah. Okay, because the aim of early PCM during the fever itself to prevent the sudden spike of temperature. So why they go into fitting? Because of the sudden spike of fevers from 38 they spike to 40s in the half an hour time. Okay, so the antipyretic is to prevent that. But even with the advice, if they want to go into seizures, they will go into seizures still. You cannot prevent it, but basically we have tried. Okay, it's not 100% foolproof lah. Some patient will still go into fitting despite that. Okay, so there is no evidence to support anticonvulsant therapy to prevent subsequent epilepsy. So okay, because if febrile fit, yeah, the diagnosis can be just simple febrile fit or complex febrile fit. Whether they are epileptic or not, we're not sure lah. So if you don't think it's epilepsy, we don't treat. Okay, unless you think it's epilepsy because very strong family history, there is some underlying neuro problem, there is some syndromic or dysmorphism you suspecting, then you can start lah. Like those patients with CP, cerebral palsy, of whatever reason, there is some brain damage. So not all CP will have epilepsy. Some CP will never ever develop seizures. Okay, but at one point later on in their life, maybe 5 years, 10 years down the line, they have fitting. So the threshold to start anti-epileptic is much lower lah, because you know there is some underlying problem and brain got some damage. So if got focus of brain that can send the abnormal signal that can trigger the epilepsy, then you probably want to treat lah, even though it's just one time occurrence. Okay, alright. So option management of inertia, patient should remain calm. We always advise this lah, but most of the time they always panic lah. Doesn't matter lah, 3 times, 4 times they still panic. Okay, alright. The lateral defibrillators, avoid inhalation, saliva. Do not forcibly open the mouth. Do not put object in the mouth. This one standard advice lah, because the main objective of this advice is not to injure the child, not to injure the caretaker. Okay, because when you are having seizures, everything become hypertonic lah. You cannot and cause injuries. Okay, but when the seizure stop, they should be able to open the mouth as usual. Okay, so the main thing to advise is to observe the type and duration. So we always advise them to record lah if somehow they have the phone with them all the time. Okay, so do not give any drug orally. So if more than 5 minutes, straight away bring to the hospitals lah. Or klinik kesihatan is fine, because klinik kesihatan got emergencies lah. Okay, because got emergency, got ambulance there. Most of the big KKs lah, small KK probably don't have. Okay, so emergency is basically the advice you should be giving, because we don't want to waste time. Because if they go to GPs and GPs don't want to accept, they have to go to klinik kesihatan. Okay, if you don't know, in GP, not every GP is equipped to deal with emergency. Some GPs has already standing instruction not to accept patient emergencies like seizures or very bad respiratory distress, because the counter is a kind of triage also. They see patient very bad, they always advise them to go straight away to hospital. Okay, if got any problem, if they accept patient got problem, then they'll be in trouble lah. So to reduce the problem, the nurses will do the triage one beginning. So the advice is important. Basically, we don't want them to waste time lah, because half an hour can make a lot of difference lah. Because you intubate late, then they become more hypoxic lah kalau patient have status. Alright. Okay, so rectal diazepam all can give. If patient have recurrent febrile fit, some of the patient will go back with rectal diazepam. Okay, all epilepsy patient with uncontrolled seizures will go back with rectal diazepam as well. Okay, Alright, more than 10 minutes. I think the seizures that lasting more than 5 minutes have last chance to stop on its own. Okay? Alright. Okay, so environmental influence on brain development. Okay lah. I'm not gonna go through the maternal part. Alright, so yeah, nutrition is very straightforward lah. Undernutrition, overnutrition, all not good for brain development lah. Too skinny, too fat, all not good. Too high sugar, all not good. I think this one no brainer lah. Okay, sleep. But I will emphasize on sleep because most of the children, probably Malaysian children, are basically sleep deprived. Okay, why? Because parents sleep late, their children also sleep late. Okay, and then they don't also take nap during the time. Okay, so yeah, every age they have their specific time duration they should be sleeping. Okay, the younger they are, the more they should sleep, the more frequent the nap they should take. Okay, in babies, in infant, at least 2 times nap, sleeping at night. Okay, plus sleeping at night. The duration tu you all can check lah. I no need to hafal lah. It's probably around 14 to 16 hours a day. Okay, and then as the children grow older, they should be taking at least 1 nap during that time, and then sleep the whole night as well. Okay, so it can be ranged from 10 to 12 to 14 hours. Okay, but the problem nowadays, what do you see the problem? If you go out at night, what do you see? Everywhere. Yeah, parents bring in their children 10 malam, 11 malam, they're still outside, not sleeping. That's the time they should be sleeping. Okay, alright lah, once in a while that's fine. Okay, if almost every day like that, every day sleep 11, 12, 11, 1, 12, 2 even, so it's very difficult lah. So it will affect the brain development, it will affect their diet. You see all these children who are sleep late, who don't sleep enough, they are picky eaters, they don't want to eat this, they are small most of the time. Because if you don't sleep, you don't grow also. Okay, so always start practicing a good sleep hygiene. You know what is sleep hygiene? Okay, sleep hygiene, parents have to basically start first. Parents also sleep late, the children will just follow. Okay, so by 8, 9 they should be in bed already, because it take probably another 1 hour to settle down. Okay, and on the bed also still can play. Okay, if the light still on, 10, 11, 12 still on, how melatonin to go out? Melatonin is your hormone for sleep. Okay, it's only will be produced if your light is off. Okay, so you probably need half an hour, 45 minutes to 1 hour for melatonin to build up lah. That's why by 9 have to go to bed already, close the lights, let the melatonin go in. Over time they will sleep on your own. Okay, so sometimes the problem with this, parents also sleep late lah. Okay, so a lot of factors. So that's why it's very important to advise parents accordingly lah about sleep. Okay, so sleep all affecting the growth, their brain development, and then if they also sleep problem can affect the your immune system as well. Okay. Okay, so the main thing about giving information to parents lah for whatever diagnosis. Okay, so when you want to explain the condition, so you must see first their kind of gauge their education level lah. Even though you don't ask, you see how they answer question, how they give histories, you probably can gauge their intellectual level and education level. Okay, some the with poor social background, you probably can tell from the way they speak, the way they answer question. Okay, so first thing first, when you basically want to explain about any condition, so you must ask their understanding first. Okay, we always ask, pernah dengar this kind of problem or not? Pernah dengar febrile? Pernah dengar? Have they ever heard about this problem or not? And some of them probably already have Googled it before when they got admitted. They probably heard the term, then they will Google it, then they will study, then probably have some idea about the problem lah. So your job is probably much easier to explain, and then probably just to clarify regarding some misconception lah. Okay, and then when you're giving it, also probably you want to giving it not everything at one go lah. So every time you explain something, after 2-3 statements, then you stop and ask, do they understand or not? Okay, don't just cakap non-stop. Okay, when you cakap non-stop, I don't know how many percent yang masuk. Okay, so always ask and stop. Ask them about their understanding. Okay, if patient going to be here for few times, you probably can basically stagger it lah. Today you just explain about what is the problem, what is the diagnosis, and then let them absorb first, think for, then tomorrow, the next day during round, you can explain a bit more, and until discharge, they probably understand all of it lah. About 24 hours you can give slowly like that lah, but if during the clinic setting, it's a bit difficult lah. But you can give everything straight away during clinic setting, but during the subsequent follow-up, you must basically ask again about their understanding. Okay, sometimes why they not compliant to treatment, why do they not taking the doing the technique whatever correctly, sometimes because they don't understand the nature of the disease lah. So basically every visit you must ask about their understanding of their own disease or their child disease. Okay, if they don't understand, they don't do it properly. Most commonly what, asthma, those yang needing compliance or medications lah, any daily medication they need to take. Okay, alright. So reassurance, okay, so reassurance is important lah. Kalau for our topic for Brafit, what are the most common question parent always ask? Bahaya? No, not really bahaya lah. Can they affect the child development or not? That are the most common question they always worry about. Okay, so your job is to basically explain lah. For Brafit, prognosis is very good lah, but the caveat is they will recur lah in certain patient, but most of the time they will get better on their own. Alright, okay. So how do we want to know your Febrile education effective or not? They understand or not? What can you do? Yalah, we put them exams lah. So we ask them and then see whether they can answer or not. If they can answer, then probably whatever you say to them, they understand lah. Okay, I always tell lah before they go back, go through bit of Viva. Okay, simple Viva sahaja lah. If they know what to do, then that's fine. Okay, but in the end, even if they know what to do, when they panic, everything cannot do anything also. Okay, because bila panic, everything gone. Alright. Alright. Okay, so yeah, I think the outcome in children with Febrile is most of the time they are quite good outcome. Doesn't matter lah, simple or complex Febrile. But yeah, basically those with abnormal development milestone, abnormal EEG finding, these are the group that basically the group that will develop epilepsy later on lah. Alright. So there are also a term we call febrile seizures plus. I mean the fever, got fever dan the fitting, but doesn't fall under the range, the age 6 months to 6 years old. Okay, so it happens 7 years old, 8 years old, 9 years old, 10 years old. So this febrile seizure plus also there is some genetic mutation or genetic cause behind it lah. Okay, most of the time need to be investigated lah. Okay, so if this patient has history of Febrile before, and after 7, 8, 9 years old they're still fitting, then you probably need to work up for all these genetic causes lah, like SCN1A gene problem and all that lah, which is related to Dravet or can be 1B, some other problem as well lah. Okay, those are the clues lah. But those with, for example, never had Febrile before, at 7 years old, 8 years old, datang with fever and fitting, then you cannot think of Febrile plus or Febrile seizures lah. You must think of some pathological problem, because at that age they can come with encephalitis, can be edem, can be ENAC, can be all sort of problem lah, meningoenceph, can be JE also. So you must basically, your differential will be different lah if you are dealing with fever and seizures during the certain age group. Okay, so in the end, history is important, examination is important. Okay, because it's just simple Febrile, there is not much neurological finding. Okay, so if patient come with all this ENAC, edem, what else yang related to the nerve, your polio, which is acute flaccid paralysis. Okay, even though they come with Febrile, you cannot ignore it lah. So basically it's something underlying pathology problem. Okay, and then to what else I want to add? Regarding that sleeping just now, I just want to add a bit more. Sleeping, if sleep deprived, they're not just underweight lah, they can be the other end also overweight, because they don't sleep at night, sleep late midnight, last makan 7 PM, at 12 midnight they are hungry already, so eat some more, then go to sleep, so there is excessive energies. Okay, so they can be underweight, can be overweight lah. So that's why very important to sleep early. Okay, I think lastly, I think probably I just want to add a bit more on the school readiness, yang the one we discussed about the milestone, developmental milestone. School readiness, what do you need to ask about school readiness is basically whether they first in terms of social skill they are toilet trained or not. If they're not toilet trained, they're not school ready. If still wearing diapers, they're not school ready. Okay, and then if they are in terms of fine motor, they can hold their pencil, their tripod grip is good or not, because there are be a lot of fine motor skill involving your writings, using scissors, whatever lah. Okay, that's another thing. Another thing about school readiness, the language skills lah. Language skill is the conversation, whether they can speak in full sentences, they can understand conversation, they can basically make people understand them. Okay, that's important, because school is a two-way learning lah, back and forth conversation. That's one thing. Another thing, whether they have behavioral issue or not lah. So they have behavioral issue means like they are ADHD, autism, they cannot social wise, they're not there yet, then they're not school ready. Okay, if disturb other people, that's a problem lah. But if the teacher call you, you don't respond, there's no two-way conversation. So that's why autism, ADHD is very important thing you need to screen lah at 6 years old, 1 year, 2 years before they go to primary school. Okay, all these things probably can be picked up lah during the preschool time lah. The teachers are very good at this lah, because they basically can see how the child respond and all that. Okay, I think lastly, in terms of gross motor, is the any physical limitation or not lah, especially got underlying neurological problem, but cognitive wise they are okay. But somehow, you know lah, the class 2, 3, 4 stories classes, and probably need some letters from medical doctors to say patient have any problem, and they need special treatment, probably need to put the class, which is that thing all can be arranged lah. Okay, lastly, in terms of cognitive skills lah, the thinking skill, where they can do some simple calculation, can understand, can do some problem solving lah. They need to have that skill also lah. If simple skill like macam 1 + 1 also cannot solve, so probably they're not school ready lah. Probably have to go into the special stream, which is your PPKI and all that. But that one need OKU card because of learning disabilities. Okay lah, so at 4, 5, 6 years old for developmental milestone screening, you must screen for that. Okay, alright. Any true seizures cannot be the term for your febrile fit lah. So febrile fit, you just should recurrent febrile fit lah. For breakthrough seizure is specifically for underlying epilepsy problem lah, because of infection, breakthrough because of non-compliance, breakthrough of some other thing lah, whatever reason. Febrile fit, you just put recurrent febrile fit lah. Okay.